Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Welcome back to Unraveled, Understanding Complex Illness.
Woohoo.
I'm here with my friend, Eileen.
You can just call me Eileen.
And I'm David Kaufman. So we are going to revisit a big deal topic called long COVID, or long hauler, or PASC, or post-infectious fatiguing illness. All these new names coming up. So long COVID. We've talked about it before.
We have, but I think that it's ever evolving.
Right.
And every time I see another long COVID patient, I learn something new. And I probably should start writing a list of the things that I learn new with every patient, but I haven't been that organized. But it is it's such a fascinating disease, and as you've said from the very beginning, it does seem to veer into ME/CFS.
Yeah. I mean, for me, every long COVID with literally just one patient exception. Every patient who's come in with a history of, I was fine, I got COVID, and now I'm a mess. They meet all the so-called criteria, the consensus criteria for ME/CFS. Mm-hmm. So they have ME/CFS, caused, in this case, by an infection, which is the SARS-CoV-2 virus. You know? And it's a pretty important concept to understand.
What's your opinion about this Ivermectin thing? Because patients are always asking me, and they often have a history where someone put them on Ivermectin, and I have never prescribed Ivermectin. Yeah. So I'm just sort of curious what your thoughts are.
I don't think there's evidence that it works. Okay. You know?
Yeah, I've looked it up, and I couldn't find it either, but you have such a long history in just treating infection.
Yeah, I mean, I think maybe it's possible that at the times it seems to work, maybe it's treating some parasite or something instead. I mean, it is a very effective drug. It's one of the greatest drug inventions ever in terms of lives saved.
Really?
Yeah, in Africa, it's a hugely effective drug.
So what parasites do you use it for babesia?
No, no. I've had patients who believe it's been helpful for Bartonella, and I've tried it. I'm not convinced.
Okay.
You know, it's pretty easy to take, so it's generally okay.
So it doesn't have any significant toxicity?
No, I haven't seen any real toxicity. I had one patient get a rash with it. But I haven't treated that many people.
Right, okay.
And to be honest, most of the time, many times when I've prescribed it, it's because a patient requested it, please, please, please. And I'll say, all right, well, I don't really agree, but I'll give it a try, And
has it ever worked for COVID?
I've never seen it work for COVID.
Okay. No. That's interesting.
Anyhow, long COVID.
Yeah.
So I'm sure listeners are sick of me saying it, but it's an index of suspicion issue. You need to find out if that patient had COVID. If the patient walks in and they say, I have fatigue and post-exertional malaise and I have brain fog and my stomach is upset and I have pain, did they have COVID at some point?
And how many times?
And how many times? And if the patient says no, what I find frequently, or certainly enough that it's now in my head to always make sure, just because they say they didn't have COVID doesn't mean that they didn't have COVID. And I've recently had a run of patients, several in a row, whose illness began in 2019 and 2020, which is just when COVID started. And it's kind of fascinating and a little scary when I ask about it. So one of these patients, it was the end of 2019. So COVID officially began in Seattle in February of 2020. So that's actually when it was first recognized in the U.S., okay? So I've had patients, for example, who in December of 2019 were at a big meeting in New York, like at the Javits Center, big convention thing, and people from all over the world, from Asia and Africa and everywhere else, and she got sick, and since then she's been terrible. Well, that was COVID. I mean, I can't prove it, but it's just too coincidental, okay? And even if I can't prove it, or even if I'm wrong, it doesn't matter. The point is she had an infectious onset of her fatiguing illness. So I'm just emphasizing that, again, the need to take a history here and try to establish the causes and when it started. So that's the first point I'd make.
Right, and also, I mean, even if the symptoms started, even if the symptoms precede COVID, the question is, did you have COVID and did it make all the symptoms worse?
Right, exactly.
And that's usually a yes, a big yes.
Right. Or
the vaccines.
Over and over, I mean, you know how I do this. I'll say to the patient, okay, when did your illness begin? It began in December of 2020 after I had COVID.
Mm-hmm.
Okay. And were you fine before that? I mean, could you do anything? You've had no limitation? Oh, yeah, I could do anything. I was great. I could do anything. Okay, let's go over your history. And again, I just had a patient this week. I'm not making this up. She said that. And then in going over the history, she had a concussion that kept her in bed for 6 months. This is all before COVID. She had two or three sprains and bony injuries, having minimal trauma to cause those. I mean, on and on and on. So she clearly, before she had COVID, she already gave me a history of a traumatic brain injury, Ehlers-Danlos syndrome, frequent infections. But to her, that was just life, you know?
Yeah.
So over and over, I will find a long history of other problems, which I sort of argue or believe set the stage for an adverse reaction to COVID. Because the other question is, how come I don't have long COVID?
Right.
How come you don't have long COVID? You know?
Right.
How come millions of people who had COVID are okay, seem to be okay?
Right. No, I completely agree. I think that there's genetic markers that make one predisposed to, but there are also risk factors. I think hypermobility is a risk factor for developing long COVID and ME/CFS. We've seen, in fact, we just published a paper out of Mount Sinai that showed that hypermobility is definitely a risk factor for CCI. And then we also had compiled other diagnoses, which included long COVID. So it seems that the hypermobile population has a greater risk of developing long COVID after
just
a
no
COVID
question.
infection. Right. So, and we talk about this all the time about the connective tissue being, I think of it as an immune organ now. And so with my long COVID patients that I've been following for years, what I also have learned to be very important is that, we both do a very extensive workup when we get a new patient. And I do a lot of labs, as do you. And I know that there's been jokes about how many vials are taken.
Yeah, right.
But do a lot of labs, and we find things, and that's I think an important point. We're not just doing it for the sake of spending insurance companies' money. They don't want to cover some of the labs sometimes, and we have to give additional diagnosis codes and all that stuff. But regardless, we do an extensive workup. But even things that were normal at that moment in time when they came to see us, I will regularly check in on. I wouldn't say every, fairly often, but maybe every 6 months. If symptoms persist and I'm not getting anywhere with the patient.
Repeat labs.
Repeat some of the labs. Not all of them. Yeah. I don't repeat all of the labs.
But that's very important. I'm going to make an editorial comment.
I was going to say, because you said you had a patient yesterday. I had a patient yesterday where there was an antibody, specifically a ganglioside, that I had checked previously. It was normal. And now it's highly positive. It's not just like slightly positive. Right. It's highly positive. Right. And that happened in 6 months, because the last time I had checked it was 6 months ago. So it proved to me, once again, that there's this chronic immune activation and that this is an evolving kind of disease. And we have to regularly check in on some labs, even if they were normal. I always say things are normal until they're not. Right. Things seroconvert. I mean, these are words that exist because this is what happens, right? So I think it's important to recognize that just because something was normal, and I say this to patients too, like when I have a new patient and I say I'm going to order a bunch of labs, they'll say, oh, well, so-and-so ordered a bunch of labs, and I'll say when, and they'll say, oh, like 2023.
Yeah.
I'll say,
so that was my editorial comment here, which is directed towards patients, okay? I ask you to send me your records, and people send me their records, and they will often send me, forget about the snapshots with the phone that I want to jump out the window. That's when I want to quit. That's one of my quit moments, okay? When I get 19 JPEGs. Okay. So they send me, let's say.
I do that to my accountant, so now you're making me feel badly.
5 years of labs, okay?
Right.
And I take the time before I meet that patient to go through these labs, okay? And then I see the patient, take my history, everything else, I order my labs, and I'll get, some of them will send back a message saying, why are you ordering all these labs? I just had them. And they list all the labs that I'm ordering and the ones they've done over the last 5 years. And I full disclosure, at that moment, I want to basically say, okay, goodbye. You can find another doctor. I don't know why you spent your time and money with me if you think that I'm not realizing that you did those labs. I have a reason, and you just gave the reason. Labs change. Things change.
Mm-hmm.
You can do a histamine 5 times, and 4 times it'll be negative, and the 5th time will be positive because of the way it was processed. Or you'll have an autoantibody that turns positive. So just a message to the listeners,
Yeah,
okay?
no,
There's a reason we do certain things.
Absolutely. Absolutely. And it's not to sort of send you to the lab a million times, and it's not to get your insurance company to pay for the lab a million times.
And we don't get paid for the labs.
No, we don't.
We don't make money on labs.
Right.
Sorry.
No, but it's true. I think I don't think patients, and nor should they. I mean, they don't really understand how how practice of medicine technically works, all those like ins and outs of it. So, but yeah, because we see these things seroconvert all the time.
Right.
And importantly, that gives us an insight into potential treatment options. And even more importantly, insurance approval for those treatment options, right? Because sometimes that's the challenge.
Right. Well, now you have your antibody, your ganglioside positive. There's a greater possibility you might get IVIG approved.
Exactly. Which is another reason why I do these labs. I go looking for reasons where your insurance company can't deny the patient the treatment.
They can deny, but you have a stronger argument to fight and waste your time with. All right, let's go back to long COVID.
Oh,
so
let's. I thought we were still on long COVID. This was a long COVID patient I was referring to with a ganglioside. It's just an ever-evolving disease, I guess, was my point.
Yeah, and let's talk about it in some detail because it's really important, and it's unbelievably interesting from a medical intellectual perspective. I mean, at this point for me, long COVID is kind of like HIV in 1982. Yeah. It's like, oh my God, the knowledge is exploding. Right. It's incredible. So there's 4 or 5. Hypotheses and or scientific explanations, ranging from the microclots to spike protein residual virus, autoantibodies, and I always forget the 4th one. Oh, ongoing infection.
Right, persistence.
And I think we see more and more each time. I mean, for those of you that are interested in following this, the 2 people I would recommend keeping track of are Eric Topol, who has endless references and explanations.
Amazing.
His podcast is great. His
the amount of time
his Substack, he's amazing, just so good, and he makes it understandable for people. The papers are there for those that want to read the papers, and then the other is this doctor that you and I met in a conference call, who I now subscribe to, Dr. Ruth.
Oh yeah,
I forgot her full name, Dr. Ruth, and
Chris. I have it. Yeah.
Anyway, and I've been putting some of her stuff up, and she's posts,
amazing. Her newsletter is incredible.
So I do want to give a shout out. She puts so much work into this newsletter, and it's not just long COVID, but it is long COVID. It's
Ruth Ann Crystal.
So
Ruth Ann Crystal, MD. She's a retired OBGYN.
Right.
But she's got Dr. Ruth's newsletter.
It is so good.
Dr. Ruth from. But she's got a newsletter,
and it's not only long COVID. It covers, a lot of other healthcare things.
Her recent issue was government updates.
I was just going to say she's now doing some politics, which makes me even more in love with her, and it's great.
Phenomenal.
Right.
I love it.
So the point is, this is a rapidly evolving frontier, and we've done more than scratch the surface of what's causing long COVID. But we ain't seen nothing yet.
No.
And I think one of the scary things is, for you and me and many of our friends and colleagues on Mastermind and stuff, it's easy to diagnose long COVID. All you do is think of it.
Yeah.
You know what I mean?
Right. I mean, the history tells you.
Right. It tells you. But I think we're going to see down the road a different phenotypes or versions of long COVID. For example, I think we're going to see a real spike in neurodegenerative disease.
There's no question. I'm already seeing it. And that's very scary to me. Yeah. Which is why I've really elevated my workup for these long COVID patients, and I'm embarking on even more sort of science on it. And I'm writing a paper on it, as you know. I've shared with you that I'm really finding a very strong what I believe to be a secondary mitochondrial component.
So mitochondrial, neurodegenerative, We're going to see increased atherosclerotic heart disease, just like in HIV disease. There's an increase, all of this related to inflammatory issues, chronic ongoing inflammation. It's not always overt or obvious. When it's obvious, that's the ME/CFS long COVID patient, so to speak. But I think we're going to see a huge bump in this globally, not just in this country. And
No, we
that's
do
another
agree with
reason
you.
to be
Yeah.
terrified about what's happening here, frankly.
I really am terrified. I mean, so I'm seeing in young people with no obvious risk factors these elevations of certain proteins like amyloid, tau, synuclein, and who are performing poorly on the neurocognitive testing that I do, that most neurologists do, and they were highly functioning, highly productive human beings before they, and it's usually not just one COVID infection, by the way. It's usually multiple COVID
multiple
infections, which of course brings us back to like, why are we denying the fact that COVID is dangerous, and why are we not masking more often and not doing more of the precautions that we had done earlier on in the pandemic? I mean, I have air purifiers in every room.
But that's when I said terrifying, I'm sorry, I was referring to the political milieu right now.
Let's ignore
this is really scary,
Really scary.
Forget about the fact that we're likely to have a bird flu pandemic, and that's not even going to be discussed.
Oh my God, have you been following that?
Yes.
That should be our next topic.
But, we have this guy and this administration who basically, I mean, part of me thinks they're just going to be happy if a lot of us die off,
I think that's what
there'll
they
be
want.
less people, so there'll be more money for them. I don't get it, but it's really, really scary. And if the research stops, which is what they're trying to do, we are so fucked it's beyond belief.
God, that defunding of research initiatives, that is going to set us way back. I mean, the only hope that there was that there was a lot of research going forward so that we can learn more and perhaps do more and prevent more. But they've taken away that funding, so that research will no longer exist. And I don't know what we're going to do. I really don't. I mean, I think we're all going to die.
I think another thing to make clear about that, so they take the funding away. If one of the answers of what are we going to do is, well, there'll be a change in administration and then they'll restore the funding. What do you think those scientists are going to do? They're going to just wait around?
Yeah.
They're going to go sit on the beach and make sandcastles until they make more funding? No, they're going to go on and move on in their life and do other things. Yeah. And that research is dead in the goddamn water.
Right. And it's not going to be that easy to resurrect it.
That's what I'm saying.
Yeah.
Yes.
And that's the scary part of it. And also, what are we going to lose in 4 years, right? The knowledge that we can gain in 4 years of constant research and constant dialogue will be lost. I mean, that's actually how science works. To have to go back and revisit a topic that was dead in the water, like it takes a lot more energy. I mean, if, just talking about like, what's that word? That's another physics word. We've been into physics lately.
Momentum?
Not momentum, like
synergy.
Tropy. The trope, like
entropy?
Entropy, right. Like, so we're going to lose the entropy is what I'm trying to say. But it didn't sound in my head.
I'm not sure that's right.
Yeah, it doesn't sound right.
But you are raising another important point, right? So Trump and Musk are banning conferences and banning travel. Where do you think scientists learn? They don't learn only in their lab. The reason they go to conferences is to talk to other people.
That's right.
I have a son who's a physicist, and he travels all over the world doing these talks and colloquium and giving lectures. And I'll often say, why are you doing that?
Yeah.
Why is that part of your job? And the answer is, that's where I learn. That's where I speak to this physicist here and here
That's
and
exactly
here
right.
in all countries around the world. And you get this amazing synergy of knowledge. And basically, they're stamping that out.
They're completely stamping it out. And that kind of collegiality and collaboration that is more informal than formal research, basically what you're saying, is just going to be gone.
Yep.
It's going to be gone.
Yep.
And that's very scary, because what we're seeing in the clinic are these long COVID patients that they just are getting worse and worse and worse. And, we try to implement sort of stopgaps. It's sort of how I see it, right? Stopgaps with all the medications that we use, which, to be completely honest, part of me just sort of like, I dread this idea of like, okay, let's try this medication. Let's lower this dose. Let's increase that dose. Like that whole back and forth when the needle isn't really moving dramatically, I feel like it's a waste of the patient's time. And I also feel like I'm just watching them, like symptoms just sort of be heightened. And and it's very frustrating as the clinician trying to sort of rein this in, you know.
I definitely have patients like that, but I'd like to, no, I don't want to say it that way. I was going to say I'd like to believe, but that's not true. In fact, it's a very small portion of my practice. They are a devastating portion, the patients I can't get better. But I have a lot of people every week who are better. I mean, I had, again, this week, I had a new patient. I saw her in her first follow-up, and she was actually significantly improved. 30, 40%, because I try to kind of get a functional grade, just by some simple interventions. So that part is not what scares me. What scares me is part of the reason I think we make a difference and can get people better is that every week I also learn something new. Somebody says, have you tried this? Have you tried Sulodexide? Have you tried Maraviroc? Have you tried? So a new idea comes up every week, so I don't run out of weapons, okay? If the government shuts down, which is what's happening, and the research shuts down, those ideas are going to shut down. And I might as well just quit. Because I won't have those tools.
Don't quit.
No, you know what I'm saying.
I know what you're saying.
And
I understand
I think
what you're
it's
saying.
important for people, we're so off course in a way, but for people to
not,
realize
this is what
is going on in DC impacts your life at home every single second. This is not some ambiguous, oh, it's just them, don't worry about it problem. This is for fucking real.
No, the decisions that they're making affect us and affect our patients and affect how we treat our patients.
Right.
There's no question. I mean, the ideas that we share will just go away. There won't be that kind of exchange. Just it's, and with all those doctors that we talk to on that listserv, well, you talk to at least. We're all gonna not have anything more to say or anything new to say.
Right.
I'm gonna be reading the same thing over and over again.
Anyhow, so back to long COVID.
But this is long COVID, though. It's my point is that I don't want to speak for you, but I know this applies to you. I regularly repackage, repurpose, use off-label, different medications for my long COVID patients. Yeah. That's what I'm doing, and I want to continue to do that. I really do, and I have found that the more effective treatments are, when I find. I'm trying to figure out what I think is most effective for long COVID, and I think every individual patient is just so different. But I have had a lot of improvements with, of course, the plasmapheresis, but some interventions with regards to mitochondria, some interventions with regards to clotting, some interventions with regards to the immune response to COVID, whether that's mast cell control or adaptive immune responses control, which is the antibodies, the T cell exhaustion component that we talked about at that one podcast, which I thought was incredibly well. People still bring up that particular episode to me all the time. So, I think it's individual with regards to what patient will respond to what, and sometimes it's hard to know exactly what to start with. But regardless, I think all of that is going to go by the wayside if we don't continue having this constant dialogue and collaboration and research. Right? It's the research that brings the idea. And then some doctors try it, and then they share their experience, and then we have conversations about what the experiences have been, and then we decide and then I decide whether or not I feel like there's enough for me to want to try it. And sometimes I decide, I don't know, one doctor that I particularly respect felt like it wasn't helpful at all, so maybe I put it on the back burner for a while. I mean, I'm not kidding. I make those kinds of decisions.
I know,
and I admit they're fairly subjective sometimes, but it's just based on the conversations, right?
It's based on conversations, and the fact is, especially with repurposed drugs, and I think everybody knows what we mean by that. There are very, very few clinical trials, randomized, placebo-controlled, gold standard clinical trials to help us make that decision. I mean, one of our most common drugs that we use, I prescribe at the first visit almost every time, is low-dose naltrexone. There's yet to be a clinical trial for that drug, okay? It works. It works unbelievably well in a huge percentage of patients. I should wait and make you suffer because there's no clinical trial to evidence-base my decision?
Right.
It's obviously ridiculous.
Right. No, absolutely. And I mean, I do have some patients that have side effects to it.
Of course. But,
at tiny dosages, so.
Yes.
Which is always problematic.
But then don't throw it out.
No, I never do.
I mean, it doesn't mean you shouldn't try it for other people, of course.
Oh,
There's
no,
side
of course.
effects.
Yeah. No, we talked about low dose naltrexone, ketotrophin, and cromolyn.
Right.
Right.
Well, this patient I just mentioned,
Mm-hmm.
she was better because we did a trial of Pepcid and Zyrtec.
Oh,
I mean, come on.
she didn't need you for that. She
Right.
could have went to the
right,
drugstore.
Right. And she'd probably stop seeing me soon because she's much better, which is great. Nothing makes
No,
me
of course
happier.
it's great. Absolutely.
You
I love when patients don't need me. I always say you don't want to need a neurologist, right? I mean, even our previous episode on the
Right.
CSF leaks, like, that just sucks.
Yeah.
There's no other way.
Anyhow, back in terms of long COVID, I don't know what your experience has been, but for me, the reason I keep saying ME/CFS, long COVID, is that virtually every one of the patients has some or most of the septad picture. They all have POTS. They all have hemodynamic instability or dysautonomia, whatever term makes you happy. They have perfusion problems. How's that? The PP, they have P squared, perfusion problems. They have mast cell activation syndrome. They have motility and SIBO. They almost always have connective tissue disorder. They may or may not have autoimmunity. And they almost always have, obviously, infection from COVID. But if you look, unfortunately, often you'll find if they're in a proper exposure risk group, reactivated tick-borne infection and reactivated EBV. I am getting EBV PCR positivity in 75% of the patients.
Me too.
That's mind-boggling.
Me too. I see reactivation all
to the
of
point
the
where I
time.
called the lab
then
to see if it was a mistake.
You do?
Well, because it's so frequent.
I see it all the time. And then I hone in on neurodegenerative disorders because we know that EBV has been associated not only with MS, but with Alzheimer's. And then I've been doing more amyloid and tau testing. I've been doing more lumbar punctures. I've been ordering more PET amyloids. And I've been really honed in on neurodegeneration in these long COVID patients lately. And it scares me what I'm seeing.
Yeah.
And I don't want to be Chicken Little because I've been accused of that in the past. I've been accused of a lot of things. But I'm really scared. I really am.
No, I agree. And I one of the reasons it's scary is you and I are seeing the tip of the iceberg.
Oh,
right?
yeah.
Long COVID, as we use the term, that's the tip of the iceberg. Under the water are all the other tens of millions who had COVID and don't seem to be sick yet. All right. And I know that's alarmist or Chicken Little, like you're saying. And I could be wrong. Maybe I'm wrong. But I think the evidence grows daily that the lower end of that iceberg is going to be a big problem for us.
I completely agree with that. I think that sometimes the delayed response is scarier than the acute. So I think long COVID, when it's obvious, when there was COVID infection in the last year even, or even 2 years, if there were several of them, I think that's one kind of pathophysiology that is largely related, or maybe, I don't know, I'm sort of theorizing a little bit, but, to the immune response that just sort of lingered and went into the cell danger response kind of thing. And there's this strong mast cell component that can be managed. And there's a strong, immune component that I think can be managed. There's all these immunotherapies that I've been prescribing that have been helpful. There's, I think a strong mitochondrial component, which there are some ideas for. I think those that don't develop sort of this classic long COVID definition, but have had multiple COVID infections, I think that things are like simmering beneath the surface.
Yeah,
and that really scares me.
Yeah, and I think that group that we're talking about, and I'm really glad we're focusing on this now, the simmering group or the under the water group, it's not going to be necessarily obvious that what they end up having is, quote, long COVID, all right?
Right.
They may just begin to appear in their doctor's offices with what is really premature cardiovascular disease and premature Parkinson's disease and premature dementing illness.
Correct.
Or, I can say it another way, premature aging, because they are going to have or may have ongoing chronic levels of inflammation, which is what aging is all about, and that will bring these illnesses earlier in life. And that's very scary.
Very.
It's one of the reasons in my regular long COVID patients, a lot of quoting today, is I'll do things like I look at the lipids now. I'm not supposed to do that in a sense. I'm a specialist in ME/CFS. Your primary should be taking care of your cholesterol. But I've come to the conclusion that's part of this disease. I want to know what it is, and I'm going to aggressively treat that because that is going to add to your risk of premature cardiovascular disease, which is caused by your chronic inflammation, which is caused by your long COVID.
Oh, yeah, I do lipid panels, and the lipoprotein A, if it's elevated,
Yep,
I mean, I pull
exactly.
out all stops, and
Yep.
I as a neurologist, sometimes I don't even know what to do about it. But I've been prescribing statins, I've been
Yes, but
prescribing all
you're
kinds of,
absolutely right
yeah,
to do that.
yeah. I mean, because it scares me what's going to happen to these patients, and I need to protect them. And because I am considered a long COVID specialist, which I embrace actually, because I want to be, I want to help these people because I see this as I see all of these things as neurological diseases, as you
I
know.
mean, I would go out on a limb here and say to people watching, um, if you know people in your family or
Hmm.
friends who've had COVID and they don't have, quote, so-called long COVID, I still think they should get a advanced lipid panel
Yes.
and an LP little a and get treated, right? I would say that even if COVID hadn't existed, but now I'm saying it even more so. What's scary to me is that even now in 2025, I think that most primary care doctors don't even know what LP little a is. It's not on their radar, you know? And these are really critical tests, and they are used in order to assess risk and to motivate some kinds of
Yeah.
treatments.
And you know what's really scary to me is that I would say 90% of my long COVID patients have elevated lipoprotein A.
Yeah,
Yeah. It's really
it
scary.
is very scary.
Yeah. Because it is the first marker, right? I mean, the first thing we learned early on was sort of this microclot theory and endothelial dysfunction. And so then you think about the vessels and the health of the vessels. And
Well, I think the LP little a, so that's a lipoprotein generated from a specific gene, and it theoretically, as far as we know,
Mhm.
is not related to events. It's not like it's high because of COVID
Right.
or long COVID. The point here is if it's high because you had bad luck and you got the gene, your risks from long COVID and chronic inflammation are multiplied many-fold.
Right.
That's the point I'm trying to make.
Yeah, absolutely. It's terrifying for these patients,
Yes.
folks.
Yeah.
So,
But we can do something.
no, I agree. We actually have things in our arsenal to address it.
Right.
And so it's important to test it and it's important to treat it because I do think that's going to prevent future events down the road for them. Well, that's one thing that will help prevent because I think there are other things to address as well.
It's kind of like the model you and I have talked about with EDS and connective tissue disorder.
Hmm.
You know, what can we do? Well, I can't do anything. You have the gene, whatever it is, we don't know it yet. So you're stuck. Too bad. Bad luck. But that's bullshit.
It
That's
is
not
bullshit.
true. Yes, I can't change your genetics, but I can do everything and anything possible to reduce your levels of chronic inflammation,
Correct.
which are eating away at what's left of your connective tissue. That's a little of exaggeration, so I don't mean
Well,
to
I mean, I
scare
think the
people.
genetics contribute to the risk of how high that inflammatory response is and how long it will exist and what your risk is of going into that whole cell danger response
Right.
from that inflammatory response, right? So like I think those are where the genetics play a role. It doesn't mean we can't, yes, you're right, we're not going to change the genes, but we can absolutely intervene on what the genes are going to cause.
Right.
In fact, there's a lot of examples of that throughout genetics. You know, when a gene function is changed from a certain variant that someone holds, there are interventions to be had.
Right.
So,
It's all about what can we do
right.
with these patients, but in any patient, I'd say, what can we do to prevent that glass from overflowing?
Exactly.
You know,
Exactly.
and we have lots of things.
Yeah, and we do it. So this applies to our long COVID
Yeah.
population, and the more we see, the more we learn. And I learn from every long COVID patient, and I learn what I'm going to do on the next long COVID patient, or at least I come up with another idea or another theory, and yeah, and so in some regards, I'm hopeful for the future of my long COVID patients, and I always think there's hope first of all, and I do see people get better.
Yeah, I absolutely do.
So I think there's hope, but we need to continue research. Yeah, we need to fund this research. So
Well, it is funded.
right. Well, now.
Well, I mean, it was funded. He's
Right.
just decided that he doesn't care. He doesn't want the funding. He wants to divert it into X or something. I don't know.
Oh my God. Oh my God. Well.
So another thing about long COVID is you don't want to get COVID. Okay.
Right. Well, the precautions are
it
just
still,
as
it
important.
still surprises me, and I'm sorry if I offend any of my patients, but it surprises me when a patient flies in from part of the country to me, and it turns out they didn't wear a mask in the airport or on the plane, and they forgot they're supposed to wear it in my office. You
Right.
know? It kind of leaves me speechless. You know, you don't want to keep getting COVID.
Right. Yeah, I'm shocked. I was just on a plane recently, and I'm shocked that I was the only one wearing a mask.
Yeah. No, it's always like that.
Yeah. And I will say that I felt a little like weird, like people were looking at me.
Yeah, I know.
Yeah.
No, it's true.
I know. Yeah, I think that precautions, we should pretend like we're early in the early days of the pandemic. We should all be wearing masks. We should have air purifiers. We should try to avoid crowded places. I mean, today's Valentine's Day, by the way. Happy Valentine's Day. But Stephen wanted to go out to dinner, and I said, no, thank you. Because I don't want to go to restaurants, right?
Yeah.
On a holiday. I mean, we go to restaurants.
Yeah,
I don't want to
right,
make it
on a
sound like we're
holiday,
living
right.
like monks.
Right.
But I don't want to go on a holiday when it's going to be crowded, So, yeah, I think that we have to be careful.
Yeah. People need to be aware that those risks are out there. And it's not just COVID. Flu is a risk also.
Yeah. Oh, the flu going around this year
it's scary. It's bad. People are really sick from it.
I know, really sick. Okay. All right. Well,
what else can we say about
we're
COVID?
fear mongers. This episode is all about fear.
I was reading the paper before I came. That's the problem.
I know. I could tell you're in a mood.
Yeah, I shouldn't have done it. I've really affected my mood today.
Clearly. All right. Well, I'm going to try to
cheer me up.
Yeah, cheer you up. I'll buy you a coffee. All right. Thanks for listening about our Chicken Little episode about long COVID. But I think there is hope, though, right?
I do too.
Yeah,
and I would emphasize what we said earlier about Eric Topol and Dr.
Ruth Ann Crystal.
They're really good. And I mean, I recognize that we didn't go deep into the science today. We didn't cite all the papers. And I do try to put that stuff up. I am using social media for the papers as well.
Good. And we will take on some papers in other episodes. But I do think it was important that, we often say that I think a lot of patients tell us that the value of what we do is the fact that we have this sort of clinical experience, right? And as being doctors, we can take what we see with patients and do with patients and sort of speak about it from a clinical perspective, which I think is sometimes lost in a lot of the research papers that are out there. So we just sort of tried to sort of discuss like what we've been seeing with our long COVID patients, which I think was useful. But I also know that we will take on some of the papers and make episodes as we've done in the past on some of those important papers.
We'll try to start putting some stuff on the YouTube.
Yeah.
What do they call show notes?
Show notes. Is it? I don't think that's what it's called. I think it's just like description or something.
All right. The other thing I want to say is I presume if you're watching, it wouldn't be you, but if you have friends or family who have had COVID and don't feel well still a year later or 2 years later or 4 years later or 6 months later from their COVID, and they have any of the symptoms that you are familiar with from ME/CFS, and their doctor says, oh, you'll get better, don't worry, please tell that patient to leave that doctor and find somebody else, okay? Don't keep wasting your time being told it just takes time. You just have to rest. You just have to do this, or you have to take some antidepressants. All right?
No, that's an excellent point. Don't waste your time because there really are things that can help you feel at least a little bit better today, tomorrow, next week.
There's a lot of things that can make you feel a lot better.
Yeah, for sure. Yeah. But at the very least is a little bit better.
Right.
You get a little bit better before you get a lot better.
Fair enough.
Jeez, you're in a mood.
I know.
So yes, there are things that can help. So if some doctor tells you that you just need to rest and you'll be fine, move on and find a different doctor. You want to argue that?
No, but I know it. I know the answer to that I would get from a patient, which is, well, I can't find another doctor. And that's true. And that's why we do this show, so the doctors could learn this stuff. Sorry, but it's true. And their patient's right. When I say that.
I know it's easy to say, it's hard to do. Yeah. We totally get that. We really do. And we should need to start writing curriculum for medical schools and residencies, and so young doctors can start to embrace this stuff a little bit more.
Yeah.
Okay.
I think I'm going to stop.
Oh my God. Okay. All right, guys. Bye.
Thank you very much.
Thanks for being a subscriber. Click here. Like here.
Subscribe. Thanks for putting up with us.
Yeah. All right. We'll see you next time. Bye.